Now we're going to go into some questions to our candidates, and we'll give each candidate the opportunity to answer briefly so that we can get as many questions as possible in. Candidates, WHO is an intergovernmental organization, but all of you have agreed in writing that WHO must lead in global health and lead member states and not simply follow. What issues do you want WHO to lead on? What issues do you want to lead on? And I don't want a shopping list of issues. I want a few issues that you are especially passionate about and want your leadership of WHO to be judged on at the end of 5 years. We're going to start in reverse order. Dr. Shoshka.
My understanding is that the biggest killer is the non-communicable diseases. And we are very good in researching evidence. We are very good in finding arguments and writing reports. But what we are very bad at is finding the proper behavioral insights for change. This is one of the messages. The other is the innovative financing or innovative resource generation. In Hungary, we introduced the public health product tax. And this is not just a small levy on products. We're taxing added sugar and salt. But we did it in a way that 40% of the producers put less sugar and salt in Coke and chips, and the people eat 25 or 33% less from the products that are signed by the public health product tax. So I think if we could move towards a sustainable resource generation for universal health coverage, that would be my biggest dream, because that makes public health dreams come true.
Very good. Sanya.
So bringing reform to successful fruition, managing for results, restoring trust in the organization, very much focusing on crystal clear programmatic priorities, ensuring operational readiness in outbreaks and emergencies, strengthened action on global public good, a focus on health, climate interaction, and technical and political activism in support of the Sustainable Development Goals, and going to countries with a very clear message at the head of state level. Fulfill your obligations under the international health regulations, embrace broad-based social sector policies encompassing universal health coverage, and invest in multi-sectoral governance arrangements, because all three policy interventions will have a cross-cutting knock-on effect. And then there are two situations in which leadership is required, slightly outside of that governing body's framework. Number one, when there's an individual pressure from a member state, that is when it is the time for the Director General to demonstrate equity in governance. And secondly, when there are polarizing situations at the table, because it's 198 members of the governing bodies, and sometimes the House there is a total impasse for weeks and months on end. And that is the time when the Director General has to step in with an inspirational approach to problem solving and bringing things to fruition.
Thank you, Sanya. David.
In the Charter of the United Nations, there are 3 words that start it off: we the peoples. This structure, the multilateral system, was set up to serve the people of the world. At the moment, there are struggles. As Sanya has just pointed out, nations don't always agree. And in certain issues, like some of the big wars we have at the moment, there are terrible, radical disagreements, even in our key governance bodies like the Security Council. So what we have to do in our organizations and in the World Health Organization as the apex health body is to serve the people, and to serve them in a way that reflects what really matters to them, helping them to stay healthy, helping them to be able to access care when they're ill, whoever they are, leaving no one behind. This is what world leaders have agreed to. It is our job, leading in the international system, in WHO, to make sure that nations fulfill their obligations. There will be trade-offs, there will be uncertainties, there will be conflicts. Our job is to help find the principles and the practices to help deal with these conflicts local level, regional level, global level.
Thank you, David. Philippe.
I think that the WHO has to be the leader in global health. So for me, health is not only ministers of health, ministries of health, disease. The health agenda is huge. Security, development, extreme poverty, agriculture, water, sanitation, business. So the first thing to do is to understand that if we want to achieve the Sustainable Development Goal, we have probably to work on public health, and the WHO is the only actor who can convene. I believe in the convening power of the WHO, my first remark. The second remark is about the strengthen the primary healthcare system. In 2018, we are going to have the anniversary of the declaration of Alma Ata. It is health for everybody in the world. It is the only possibility to implement the universal health coverage. You have to strengthen primary health care system and communities to narrow inequalities. Today, we have, like you said, Flavia, millions of people who don't have access to well-functioning health systems. And it is the reason why I am sure that it is the only possibility to allow vulnerable groups, women, children, people living with HIV, people waiting for palliative care, and people living with mental illnesses to have access to medicine. So it is probably the first role of the WHO. It is to narrow inequalities.
Thank you, Philippe. Flavia.
Thank you. Three special issues where, as Director General, I will lead, as I see them as the three biggest threats that are facing global health. Number one, WHO needs to lead the response to outbreaks and emergency in humanitarian setting. Number two, WHO needs to lead in the slow response to address the impact of climate change on health, which is mediated to the change of vectors, the difference in food security, in quality of water and air. And number three, lead and address the epidemiological and demographic transition. Epidemiological transition from communicable diseases to non-communicable diseases, and demographic transition from a pyramid where at the bottom there are a lot of children to demographic in many societies where the proportion of elderly is increased. Thank you, Richard.
Thank you, Flavia. For the next question, we'll begin with David. You all see universal health coverage as a critical health goal. And indeed, that's right, because it is goal 3.8 in the Sustainable Development Goals. But what can you do as WHO's Director General concretely, and I'm looking for very specific proposals here, not general statements, what can you do concretely to advance the idea, the objective of universal health coverage in countries? David.
Thank you very much. The term universal health coverage is useful, but I want to dissect it a bit. For me, it means ensuring that everybody, everywhere, has access to health care that enables them to be able to avoid or recover from common and serious diseases. So there are three things that in the World Health Organization we can really do on behalf of the whole world. The first is to make sure there are clear measurements. Measurements of people's access to care, disaggregated by livelihood group, disaggregated by ability, disaggregated by sex. Secondly, we can work to make sure that the systems function, but we should concentrate principally on care providers, the people who produce health in their homes, in communities, in institutions, and in clinical settings. Most of these actually are women. They're often women working in the home. And so let's give much more support to and respect for care providers. Thirdly, ensuring that the systems are as efficient and effective as possible, looking at excess pricing, particularly of medicines, looking at effectiveness of care, building on the NICE experience in this country, and making sure that systems give the optimum quality of care for the least possible cost, particularly in ageing populations and among disabled people.
Thank you, David. Philippe.
For me, if we want to implement the universal health coverage, we have to understand, like David said, it is access. 2 billion people in the world don't have access to well-functioning health systems. Why? Because the human resources. It is the first problem in the world about global health. When you see that we have less than 1% of health workers are in Africa, you can understand. It is the reason why France and South Africa co-chair since the last General Assembly of the United Nations Commission on Human Resources and Economic Growth, because it's linked. The second thing is about public health. The key for universal health coverage is public health. Why? Because the budget of all the countries in the world, including Western countries, the budget for public health is ridiculous. So we have to strengthen the speciality of public health. But what is it for a health system? It's very interesting. It is not because I am an epidemiologist I am going to say that. It is because, you know, public health, it is what it is. It is promotion of health, education of health. After that, prevention. After that, screening, early screening. After that, early diagnosis and early care. So it is a key, probably. Third, the budget. If I am the DG, I am going to see heads of state, particularly in developing countries, to tell them you have to increase the budget of health. In Abuja, 15 years ago or 20 years ago, we said 15% of the budget for health. Now, some have 4 or 5, and the budget, the military budget, is at 45 or 50%. And to finish, you know, we cannot speak about universal health coverage if we don't speak about, we need a task force, a global task force for the health of migrants and refugees. It is not possible to continue to let countries like Italy, Greece, Turkey, or Jordan to have thousands and thousands and thousands of refugees and migrants, and they are alone to vaccinate, alone to avoid outbreak, etc. And to finish, we have to recognize that violences against women and children are one of the biggest public health issues in the world.
Excellent. Thank you very much, Philippe. Flavia.
So, universal health coverage. I will expand on the definition of universal health coverage in 2 dimensions. Universal, which means reaching everyone. To reach everyone, you need to know where those people are, where they live. With the services that we currently have, for example, immunization, we know on average countries have higher than 80% immunization coverage, but on average on the world, we still miss 1 child out of 5. In order to reach that child, you need to know where he is. Often he or she is not registered when he is born, and hence doesn't exist. And you need to deploy tactics and strategies. Sometimes it's the fixed facilities, sometimes it's the mobile campaign. So you need to work on the universality, on reaching everyone, leaving no one behind. The second dimension I want to expand of universal health coverage is the part that is health. And under that, what do I mean? I mean the kind of services that improve health. And let me stay with the immunization, just for the ease of understanding. Currently, in the world, in many parts, particularly sub-Saharan African, women do not have access to the primary care services that Philip mentioned for cervical cancer. Only in 30 countries of the world, adolescent girls have access to human papilloma virus vaccine that can prevent cervical cancer. But the access to cervical cancer screening is so limited. The access to early diagnosis is almost non-existent. And most importantly, the access to treatment and care and palliative care is not existent because of the cost that those drugs have, because of the capacity that the health system and the capacity that the health worker have to provide those services. So I would want to address specifically these two aspects, Richard. One, universality, reaching everyone and understanding where they are, where they live, what kind of condition do they live, whether they are refugees, whether they are migrants, whether they are internally displaced. And the second one, expand in a progressive realization fashion the kind of services that people need and that people can have access to.
Thank you, Flavia. Miklos.
Universal health coverage is a very complex issue, and in the 6 regions of WHO, it has certainly different meaning. And I'm talking about the lonely, the people in the lonely aging communities in the more developed part of the world, and then the lack of community and primary care services in the low and middle income countries. So this is a complex thing, and then WHO is a global health organization, so we have to address a very broad portfolio of issues. You know, I mentioned already that universal health coverage is a dream if we just want to build on the temporary donations and the economic potential of voluntary donors. So there has to be institutionalized resource generation. It's a long process. But we have to change the focus and start to work with fiscal and political decision makers and financial communities about innovative solutions. That is number one. It will be a long way to go. Number two is that everything, I think, when we are talking about low and middle income countries, the core for that is the development of primary and community care, and you need human resources for that. Committed people who in the community ready to take up action. Sometimes very simple one-dimension actions for the community. So we have to focus on the development of human resources and balancing migration. Hungary is a donor country. I think more than 2,000 Hungarian physicians working here in the UK. And I can understand other places where the production is not that high. What does it mean for nurses and others? You know, and the other is technology. You know, with the new point-of-care devices, and the new wearable devices, you can take diagnostics and therapy to places where they never existed before. It is like vaccination for the 20th century. Technology would be that thing for the 21st century. And if you say I'm a dreamer, the social media giant will shoot up drones and they will provide free Wi-Fi to disadvantaged countries or regions. Then would it be relaying marketing messages of our toxic lifestyle? Sorry, but would it be available for innovative behavior insight messages? Just one last: new business models. New business models. Do we procure pills, or do we procure results or production? So we should start to talk about with the non-governmental actors, to be politically correct in WHO terminology, industry I mean, or non-antagonizing industries. We have to start to talk about business models that makes access to technologies or high-tech care accessible and equitable.
Thank you, Miklos. Sanya.
You asked us and encouraged us to be specific, and I will be. There is a country and a global dimension to the question you asked about universal health coverage. If I was the Director General, I would go to a country and seek a meeting, a consultation, where the head of the state, the Minister of Health, the minister responsible for the labor market, for finance and the social sectors on the table, and I will have specific messages for each of them. To the health minister, I will clarify what we mean by universal health coverage, because they've heard about primary health care for the last several years. I'll explain to them that universal health coverage is about building further on your primary health care commitments, but this entails a long-term social policy commitment, domestic resource mobilization, and an additional commitment to financial risk protection in addition to geographic coverage. To the finance minister, I will explain how can he be the finance minister of the continent by investing in innovative financing. To the labor market minister, I will explain the implications of expanding employment in relation to universal health coverage. And to the social sector minister, I will explain the interplay that it has. And to the head of states, I will explain the importance that universal health coverage policies have for the next election. I will then commit technical expertise to them, specific to their own country. As Miklos very rightly says, this is something, health systems are very unique to individual country settings. And I will come back to Geneva and I will convene my own teams and I will ask them what their capacities are. Because technical support for universal health coverage to countries requires stepping up of WHO's own capacity in the area of stewardship, in the area of regulation, in the area of a number of different instruments to harness better the capacity of the private sector, and which provides the bulk of care in many settings. And I would flesh that out, I would explore that, I would invest better in capacity building. I would also explore the potential of partnerships, because there's a huge interplay of agencies which have expertise in technology, expertise in financing, expertise in social protection, which are outside of the World Health Organization. And I've already said, as part of the 3 elements of my vision, that one of the big changes, game-changing things I would do is to institutionalize capacity, both to foster and to sustain partnerships. And then I link back to another element in my vision document, which was precisely to provide technical support for situations such as this, where I promise to ingrain an institutional culture of the Director General's virtual roundtables with countries, because I think that it is entirely possible to mine WHO's technical wealth much better, to link in the South-South, and to give countries with technical expertise on a real-time basis in response to the questions that they ask. And I think universal health coverage is a classical example of how you convene multisectorally, how you tailor messages to different cabinet ministers, how you tell the head of state what the value it is for them in political terms, and then come back to Geneva and step up your own capacities alongside.
Fantastic. Thank you very much indeed. Sanya, I'm going to begin the next question with Philippe, please. All of you agree that the World Health Organization needs further reform. What is the single most important reform that WHO now needs and that you will begin to implement as Director General? Philippe.
For me, we have to define clear lines of accountability between the Director General, regional directors, and country officers. We have to deal with the GPG, the group policy, the global policy group in depth. At the headquarters,
what does that mean, Philippe? Can you, when
yeah,
you say
I am going to tell you. For me, the Director General and the regional directors have to define global strategies for global challenges. And we are alone in a room. We are going to work, we are going to discuss, we are going to fight. At the end of the day, we are going to be okay for a strategy. And all this strategy has to be in all the regions. It is the same strategy. We don't have to begin again a strategy in the 6 regions. But to do that, we have to make one reform. And this one, because it is your question, we have to rebuilt or built the credibility and the accountability of the WHO. And for that, the WHO should set up a new, flexible, efficient, modern human resources system with a workforce of world experts, internationally recognized, and capable of deploying staff to the countries which are the most in need. For that, we need decentralization of budgets and staff, but in one condition. At the same time, we have to set up a strong audit function, knowing that all the audit recommendations are to be swiftly, fully, and quickly implemented.
Thank you very much. Flavia.
The biggest reform, ensuring sustainable financing for the organization. This is an organization that has 20% of its resources that are roughly $2 billion per year. This is the same budget of a hospital, a pediatric hospital in Florence, in my own country. 20% of those resources are secure by financing of the countries and the member states of the organization. 80% of the other resources come through what we call voluntary contribution. They come in with a lot of straitjackets. We call them earmarks. So you have to deliver certain things. They don't give you the flexibility, for example, to have a quick response to outbreaks and emergency. And how would I tackle that, Richard? It's absolutely imperative to continue build on the number of donors that are supporting WHO, increasing the number, reaching out to donors that are currently not providing support. One of the programs that is under my leadership within WHO has a list of 3 pages long donors. These are some of the small foundations, some of the private sector companies that have foundation associated, some of the non-governmental organizations that want to partner with us. So expand the contribution and the number of donors. Work on innovative forms of financing. As a vice chair of Gavi, I've seen the power of those innovative financing, like advanced market commitments, for example, for enabling new vaccines to be introduced. So I will explore forcefully all the new ways of innovative financing that can enable the organization to be on the sustainable path. And then finally, I will continue the dialogue with the countries to make sure that those, what we call the assessed contribution, the regular contribution, over time, they can grow and they can provide that stability.
Very good. Miklos.
You know, my understanding is that because WHO's future and strong WHO depends on performance, my number one organizational intervention should be a performance management system. So we should reach out to regions, we should reach out to member states, and we should shortcut the troubleshooting in the organization, and we should make the organizational work for materialized results. So the performance, action on the ground and in the trenches. So this is a word that a director general or a captain cannot want from only from a Geneva office. Of course, that should be part of the job. But we should be there in the trenches with the member states. So this is the answer. And let me just talk about resource generation, because when I'm talking about better performance, I'm sure that that is the key for generating more resources. But you know, when I'm looking on that, WHO is able to generate 80% of its resources from outside. Of course, there are organizational risks to it, that somebody takes over the guidance. But I see an opportunity there. So if with this performance we can do that much, if we improve performance, there's a chance to make it better. And when I look on the walls in the Chatham House about the donors and I read the budget records of the WHO, I think it is a chance. That 80% is a chance for improvement if we improve performance. Thank you.
Thank you. Sanya.
Well, I can outline a number, but since you've asked us for just one, I'll say that it is accountability, and it is accountability at 2 specific levels, to be very specific. Number one, at the interface between the Director General and the regional directors. Using existing instruments, because that is where you can turn around things very quickly. And I'll give you an example. For instance, as Philippe rightly mentioned, there is the institutional mechanism of the Global Policy Group, where the Director General and the regional directors convene and discuss issues. Also, the Director General has a letter of delegation of authority to the regional directors, and then the regional directors have corresponding letters of representation, which are now in the public domain, and I'd like to congratulate Dr. Chan for making that information public. There is a huge opportunity to utilize those two instruments and mechanisms and to build further on them and to create compacts on accountability with granular details between the RDs and the Director General, and you can do that very quickly if you get consensus. The other instrument for accountability, as Flavia will tell you, she is the sitting ADG, is the other accountability compacts between the Director General and the Assistant Director General. I have studied those in great detail, and the indicators outlined for accountability are not specific. There is much potential to take them to a much granular level, and I believe in extrapolating and putting a layer of risk-based accountability on top of that. Where is the risk in the organization of going wrong? Which specific indicator do you use to measure that risk? What is the means of measurement? Who is supposed to keep an oversight? Who has responsibility for delivering on that indicator? Who has responsibility for oversight? And how does that cascade into performance evaluation matrices? I think that if the Director General can get accountability firmed up in very specific terms in these three instruments at these two critical interfaces within the first few weeks of assuming office, it will be a good start.
Thank you very much indeed, Sanya. David.
Thank you very much. I want to focus on WHO playing the best possible role it can in delivering results in relation to health threats like major diseases, health systems as they struggle with aging populations and new technologies, and universal health coverage. That's healthcare for everyone. But if we try to do it just focusing on that organization where there are 8,000 people whose email address is who.int, we'll just not succeed. Because year on year it's expected to do more. Year on year its budget gets tighter and tighter. So let's look at it differently. Let's recognize that WHO will in future be a curator of a managed network for world health that will involve the expertise within its member states, like all the capacity here in Britain, but also in many other countries, in southern countries who've got growing expertise and much to teach the rest of the world. Let's focus on the relationships that exist between WHO and these different actors. Let's focus on partnering as a skill, as Sonia was just saying, mutual accountability, how we're all working together, building a culture of trust and effectiveness that reflects a movement rather than reflects an organization. It's doable, but actually we've started to do it in so many areas by necessity, because the institution itself is just not going to grow in the way that we'd all like it to.
Very good. Thank you, David. Now, we started a few minutes late, so I'm going to steal a couple of minutes from your coffee. We've got then about 6 or 7 minutes left. And now what I'd like to do is ask each of you a different question, a very specific question based upon what you've written in the responses you gave to us, and I think were distributed to people in the room today. And I'm going to begin with Sanya. Sanya, in your answers to questions that we put to you, you recognized the fragmentation of the global health system, and you wanted WHO to play a key role in addressing that fragmentation. And you write that you commit to investing in, your words, a coordination-centered capacity-building initiative as one of several specific commitments in my pledges. What is a coordination-centered capacity-building initiative?
Well,
That's a Richard, I know.
I'll outline the intent and the broad principles behind it. mandate, and the premise is that WHO is the world's leading health agency, but it is not meant to do everything on its own. It has certain core mandates, and it needs to focus on those core mandates, and it should exercise leadership through a shared vision, by recognizing the importance of complementarity and comparative advantage. And we also have to recognize that we are living in times where there are specific asks of international agencies. So the Sustainable Development Goals have created a very different paradigm compared to what was the norm in the past. The environmental, social, and economic determinants of health. The recognition that factors outside of health sector play a very important role. The imperative of deep interlinkages between the humanitarian, climate change, and development-related work, and the unprecedented opportunity provided by rapidly advancing science and technology and information communication technology necessitate new leadership competencies, new institutional approaches to partnerships. Now, partnerships is a very nice word to have in every document, but how do you cascade it into implementation? And I'll just finish. And you need to have specific skills for that, and a specific mindset and an institutional culture. So I will convene the best experts in order to create the mechanism to build capacity within WHO to think and act differently.
Very good. Thank you, Sonia. David, in one of your responses, you talked about the importance that safe spaces exist for all parties to interact with WHO, creating safe spaces for all of WHO's stakeholders. That's an objective that's defeated the current Director General over the past 10 years. How are you going to succeed and be different?
Thank you, Richard. Well, you never know what's going to come with these kinds of things. This is a safe space. Most of the last 30 years, I've been, in a way, doing what Sonia just talked about, which is specializing in that skill of partnering, of bringing people together so that they will leave their kind of institutional priorities at the door of the room and then come in and work together on the problem, basically dealing with it from first principles. But to create those kinds of spaces where people will work together in a collaborative way, in synergy, is not straightforward. Why? Because you're always worried that what you do when you're trying to work together with others will leave you vulnerable when you go back to your own organization and you're accused perhaps of giving away ground in the battles that tend to exist inside any collective endeavor. A safe space is one where people can come together and know that they're actually not going to get penalized, either for what they say during the negotiations to work together or when they go back to their base organization. How do you do it? Number one, protect everybody's power. One of the challenges in bringing groups together is that levels of power differ. Often you get groups who actually feel that they don't have as much power and they feel trampled upon by others. So you need specific mechanisms to make sure, for example, that non-governmental organizations, patient representative groups and others don't feel they're going to get perhaps given a bad time by governments and others they're working with. Second example, I'm only going to use two, is that you make absolutely certain that when people do come together and seek to find ways to work together, you give them space to go back to their original organization and check, do a referendum to see that they're okay. With many of the things we're doing with groups of NGOs at the moment, they need to be given the chance to go back to their membership and get the cover. Those kinds of issues, political cover and an opportunity not to get your power base destroyed when you're doing this work.
Very good. Thank you, David. Philippe, you emphasized today and in your responses to us how important it is that WHO demonstrates that it's achieving impact, results. That's a big commitment. How are you going to do it?
So we have to, first, for example, for emergency response, I would like to implement an independent advisory committee which is going to review all the decision-making and all the responses of disease outbreak to know if we work or not. So I think that we have to demonstrate consistently that when we put a funding, we have an expected results. So it is the only possibility to increase the accountability and the credibility. When I was Minister of Foreign Affairs in 2006, I created a group which is diplomacy and health, and to enhance the importance of global health in diplomacy. And in this group, we emphasize the necessity to link funding and results.
Very good. Thank you, Philippe. Flavia, in your statement, you emphasized the importance of using a human rights-based approach to health and sustainable development. Everybody talks about human rights. We all believe in human rights. How can your approach to human rights be different from anybody else's to make it a true success?
Thank you, Richard, for asking that question that is so close to my heart. It's not that it has to be different. As I said at the beginning, the right to health is in the constitution of the World Health Organization. What we have to tackle is the resistance and sometimes really the opposition that many policymakers, particularly in health, have. They feel threatened by using a human rights-based approach. And the way we have done it, and I have worked specifically with Professor Paul Hunt, the first special rapporteur for health and human rights, was to tackle it from the evidence angle and begin to analyze what's the evidence that if you use a human rights-based approach, actually you improve the health of your people. And we published the first ever monograph that WHO published on that topic, highlighting that the countries that have the right to health in their constitutions, that have the right to health spelled out in their policies, in their law, actually they do see progress on the health of women and children. In addition, evidence is one aspect, but the second aspect is coherence. Currently we have groups of bodies in international organizations that work on human rights. We have the Human Rights Council, we have the Committee on the Right of the Child, the CEDAW Convention. They work on human rights, and then we have the international agencies and at the top, at the lead, World Health Organization that work on health. There is no coherence between those, the dialogue on advancing a human rights-based approach to health. And what we have started is to create a working group that actually you, from the independent expert review group, when you were chairing that, you asked for it. You said, create a group that enables that coherence and that dialogue to happen. That's what I will spearhead, and I will advance concretely. Thank you.
Thank you. And then finally, Miklos, in your responses, you conjured up this interesting idea of rapid response teams and task forces to address urgent problems that WHO faces. What is a rapid response team? Is this a group of experts you put together and drop into a country to address a problem?
Part of this issue is addressed by these emergency medical teams. So that is a global network. But I think we could go even further than that. You know, when there are missing local skills or missing local capacities, there has to be a global mobilization. There has to be people who commit themselves to public health purposes or humanitarian purposes, but we have to make it more institutionalized. The emergency medical teams is a good movement, but I think we can reach out to medical universities, we can reach out to professional communities in a more operational and more institutionalized sense.
Miklos, thank you. I'd like to ask you to give our candidates a warm thank you for their fantastic responses this afternoon.